Hi, good evening and welcome to the 11th KOL webinar, coming live this evening from our Manchester office. Thank you all for joining us this evening. Over the past 3 months, we have delivered these webinars every week, and it's great to see there's still interest out there, with over 200 people joining us tonight from all over the UK. There's still more to come in July, so keep an eye out for those invites. So an interesting and relevant topic this evening, as healthcare moves into a new phase and the treatment of patients is looked at differently. Our speakers tonight, Ioannis and Tim, will explore cruciate ligament injuries of the knee, how they can be treated conservatively, and the role of dynamic knee braces. Our very own Giles Leeming will then go through the features and benefits of both the rebound ACL and rebound PCL, which are the world's only truly dynamic force knee braces. As some of you have joined before, you will have seen these, but for those who have not, we have various camera angles that allow us to go through those product features and also live fittings. We just go from the main camera here, we can then go to the table cam. As Giles is showing a brace. We can then go to our treatment couch cam, where Giles will be fitting a rebound PCL and ACL to me later this evening. And we also have a fitting area at the back of the room, which allows us to go through the intricacies of each brace whilst fitted to the patient, i.e. me. Just so you know that we can also use these for one-to-one training sessions at any time through the week. We do have several customers who have training set up on a variety of products. So if you do wish to arrange that, please contact your local area sales manager, email us directly, or if you want to mention it in the chat tonight, then you can do so and we'll get back in touch with you to arrange. So just to go through the usual housekeeping setup, please do use the Q&A function at the bottom. We like to make these sessions as interactive as possible, so ask any questions through that function, and Giles will be manning that this evening. There's also a chat function that you can use. This evening's webinar is recorded and is posted on the Össur Academy YouTube channel, usually 48 to 72 hours after the event. You can also look at our previous 10 KOL webinars on that. You will receive an e-certificate after the event. Do check your junk mail inbox, as sometimes they do go in there, and then save as a PDF. And then we will follow up with questionnaires. So do please fill them out if you have time, just to give us an idea of other topics you'd like or other ways that you think we can enhance this, this platform. So just to go through a little bit more about our speakers this evening, we've got Ioannis Pengas. Mr. Pengas had undertaken both his undergraduate and postgraduate training here in the UK. He completed his trauma and orthopaedic training through the prestigious Percival Pott Orthopaedic Rotation Base at St Bartholomew's Hospital in London. Thereafter, he honed his surgical skills and experience by undertaking 2 highly sought-after posts, knee fellowships, initially with Mr. Tim Spalding and Pete Thompson at Coventry, followed by the Basingstoke Knee Osteotomy Fellowship. He was subsequently appointed as a trauma and orthopaedic consultant knee specialist in 2016 at the Royal Cornwall Hospital. Being interested in the native joint preservation solutions covering both non-operative as well as operative options, he joined a number of societies, including the Biological Knee Society. In 2020, he had the privilege of becoming the co-convenor of that society, which hosts world-renowned national and international guest speakers. So we're very lucky to have Mr. Pengas this evening. We're also very lucky to have Tim Powell. Now, Tim qualified as a chartered physiotherapist in 2001 from King's College in London. After a brief period of working in the NHS, he worked with the military, and this allowed him to develop his interest in sports and exercise injuries. He has completed master's degree in training in sports and exercise medicine. Over the years, Tim has provided physiotherapy support to numerous athletes competing at international level in women's rugby and women's football, sailing, swimming, taekwondo, modern pentathlon and platform diving, attending several international meets as part of their medical support team. He now works at NHS at Royal Cornwall as part of the knee orthopaedic surgical team as the county knee specialist physiotherapist. Tim also has a strong research interest, achieving funding to undertake clinical research with focus on hip pain in young adults. So yes, we're very lucky to have 2 prestigious speakers this evening. I hope you do enjoy the evening. Thank you for attending, and I'll pass over to Mr. Pengas.
What happens in the ACL deficient knee? This is an interesting, some interesting studies there. We noticed that in the ACL deficient knees, reduction of anterior tibial oscillation was noticed. Better patient-reported outcomes were reported, and also reduced episodes of perceived knee instability. But again, we don't know what else is this braces doing in a deficient knee, and as a surgeon and possibly as a patient, the interest is, does it reduce the secondary injuries to the meniscus and maybe some chondral injuries that patients waiting on the NHS for their operation may demonstrate. We know that the meniscus, for example, has increased rates of meniscal tear, mainly the medial meniscus, the longer we wait, and also the repairable meniscal tears seem to reduce the longer we wait. So there was a really good study, I think, from Canada that looked at the state of the knee, an intact native knee with an intact ACL, a torn ACL, and a reconstructed ACL. And I'm just going to focus on the bits that take-home message, as it were. The meniscal strain, notice in this computer model study, was reduced in every single state that the knee was under, and more importantly, in the ACL deficient state. And that's the biggest percentage change, which is of interest to us as surgeons, because this is a thing where this dynamic ACL brace may find its home, in my practice for sure, because the waiting list that I currently have, and I've been told is not that bad, is about, there you go, your Cornish seagulls are in the background, it's about 9 months now, and with a post-COVID, this is going to increase significantly. So if we can reduce the strain on the medial meniscus, which is the secondary restrainer of the anterior tibial circulation of the knee, then potentially we save the patient bigger surgery or unnecessary surgery, then they save the NHS money on consumables and also time in theatre. So although there is a price of the brace, then on the flip side is less operating time and less unnecessary operations, potentially a knee in a better state overall. Another group that potentially could be useful, this rebound braces, is in the adolescent population. I'm not sure if this brace goes down to really young children, but this study from the States with Defilis looked at adolescent and pediatric patients retrospectively with MRI and they identify where the tears were in the ACL, whether they were proximal, pilous, or tibial spinal avulsions, and everything in between. And it's really interesting to see that if you're pre-teens, mostly it's tibial spinal avulsions, and as you go more towards adult, it's a more adult picture of where the ACL tears. The most interesting finding is that there are subgroups where there's either a complete proximal peel-off, 1 in 3 patients roughly, or at least a Sherman 2. And that is where some of my colleagues think ACL repair may be a good tool to use. And I know, certainly in my fellowship, we use the fiber tape as a check rein to protect that repair. Unfortunately, that means that there is suture material inside the knee, which shouldn't be a problem, but it does require a second operation to either cut the tape or remove the tape, which means extra surgery. And if that brace proves in studies that can protect that repair, potentially that, again, is saving the patients an extra surgical intervention with whatever risk that entails. So that's where we are with this. I think it could be used as a shield to your ACL repairs. The other question is it a good tool to use post-operatively? We're going to have to find some data again, but this is the chart from the same study that does show that there's a reduction in the strain on the reconstructed ligament while wearing this brace. And that may mitigate against stretching of the ligament in certain patients. I don't brace my patients as a rule, unless I think they need bracing for extensive medial meniscal repairs. But that potentially could be something that a study can highlight down the line. So to summarize, on the ACL front, my take-home message would be that this brace should and hopefully would prove to be useful in prevention of further meniscal and chondral damage, and certainly in the prehab phase of the patients. It may, if the relevant studies prove that is so, be useful also post-operatively, especially in patients that you feel that they might need some further protection. And so that's where my thoughts are on this relatively new tool in our armamentarium. Certainly I've used it in a couple of pediatric patients which decided to treat non-operatively, and we'll unfortunately, due to COVID, we don't really have hands-on on that, but I'm sure we'll find out how they get on down the line. It might also be useful post-operatively if someone has a tibial spinal avulsion that you want to treat non-operatively, or tibial spinal avulsion you treat operatively. You want to protect your repair of the spine. So there are some obvious common sense, if I may say, potential uses. Studies need to be done to prove it that is useful, like everything else. So we'll take us swiftly into the PCL, and the PCL offers it's a big ligament at the back of the knee. Is a primary strain of the knee to inflection, very minor role in rotational stability. If it's neglected, most studies have shown anteromedial degeneration. Certainly, in isolation is very rare. I think it's about 1 in 5 PCL injuries come in isolation. Most of them, like this case, is a multi-leg situation. It does have the ability to regenerate, though, and this is the same patient that we found from our MSK colleagues' archives. That in 2009 they had what looks like a complete PCL tear, and lo and behold, 10 years later in 2019, if you didn't know that there was a PCL tear 10 years before, and you looked at this scan, you might say it's a bit attenuated, but it's in continuity. So it does have the ability the intrinsic ability to heal. And most studies that looked at the PCL treatment non-operatively, they were focusing on isolated PCL injuries, probably not grade 3, and the early results had good subjective outcomes, not so good, or some might say poor objective outcomes. And the poor outcomes were attributed down to the attenuation or stretching of the PCL when it healed. It didn't heal in its normal length, and the anteromedial and patellofemoral degeneration that was noticed. And this is a case of a patient that had a Ruth Goldway operation when she was young, and a clear subsequent PCL injury, and she has, you can see the translation and the degeneration there. Okay, so 5 years down the line, as I said earlier, we've got about 50% or more medial compartment degeneration with 30% PFJ degeneration. And so how do you identify the people that don't have a grade 3 or a multi-leg injury? When it comes to PCL clinically, we all know about the step off. So normal step off at 90 degrees, that the tibia is anterior to the medial femoral condyle, and then grade 1 is a little bit less so compared to the contralateral side. Grade 2 is flush, and then if you feel the femur before the tibia, then that's probably a grade 3, and I wouldn't really go for a non-operative management on that situation to start with, unless have a case unless you feel that it's indicated. So, but how to quantify it? It's very easy to say clinically. Laprade, again, in one of his many papers, has given us some values. And so if you find that in stress x-rays are using a bed of nails, as in this case, or the TLS device, then anything more than 12 such side difference, then you think is a multi-leg. Anything below that, I think is a fair game to use non-operative management, and certainly the rebound brace is really good there. And we know that rebound brace, again, from this study from Laprade, has the ability to restore the ligaments tension. And that means that it brings it back to its physiological length and it aids healing in that position. Which brings me to what do I use the rebound brace and how do I incorporate in our practice here in Cornwall. We use it in acute situations, mostly in grade 2, I would say, maybe grade 1, but mostly grade 2. We have used it like in this situation here in a grade 3 multi-leg patient that we could not intervene to do anything operatively because he had a lot of other issues and comorbidities. I also use it in chronic situations, and it's really interesting to think of this brace something along the lines of an offloader brace, where if you're considering someone for an osteotomy, you try the offloader and see if they have the offloader moment. We use it, we know it's an expensive brace, but we use it to, one, gauge if the patient feels that the knee is back where it belongs and back to what their perceived normal is. That is an indication that potentially these patients may benefit from surgical intervention. And number 2, to see whether the patients can tolerate the brace. And Tim will talk later about rehabilitation, but the brace is an integral part of our rehabilitation regime, and therefore if a patient cannot tolerate any type of rebound bracing and does not feel or perceive that this has been a good thing for their knee, potentially they have to have another consultation because they won't do well from undergoing big surgery, potentially with all those risks that we all know PCL surgery comes with. And postoperatively also, it reduces the strain on your graft, which we know the PCL stretches quite a bit. I think Tim also is going to speak about that. So I'm going to stop there because I don't think I have anything else to add. And if you can ask the poll again, Giles, if you don't mind, find out if.
So similar to the poll from beginning, it's just a discussion, following this, what other sort of conditions would you consider trying a rebound ACL or PCL for? So acute ACL, post-op ACL repair, post-op ACL reconstructions, acute PCLs, chronic pre-op PCLs, and post-op PCL reconstruction. There we go. So those answers just coming through. We're up to about 50%. I'll leave it on for another few seconds. There we go. And I'm just going to stop it there and then share those results. So you can see 63% consider it for the acute ACL, 52% for the post-op ACL repair, 49% for post-op ACL reconstruction, 71% for acute PCL injuries, 65% for chronic or pre-op PCL in a diagnostic capacity, and 65% post PCL reconstruction. Okay, fantastic.
Any questions or anything you want me to tackle now or later? We're here.
There was a question from Jamal with regards to ACL or PCL braces. Are there any sort of situations or patient groups that you consider using them for recovery from an injury, sort of long term?
Just to clarify, is this something that the question was whether you can use these braces as a definitive treatment in a ruptured ligament?
I think it's more what sort of situations do you use braces, perhaps to return to activity and that sort of thing? Are there any sort of situations or sports, for example, that you consider brace usage might be helpful for?
Well, certainly if patients don't want to have they are non-operatively managed and they have, in the prehab phase, yes, but I wouldn't send them back to activity in a brace personally.
Okay.
And that is my that's my short answer, really.
Okay. And there was another question from Julia Arthur, just basically asking about why does the PCL have better healing abilities rather than the ACL? Can you just sort of discuss around that at all?
I think Tim is talking about that in his talk, so I don't want to steal his thunder a little bit.
No worries. So should we perhaps move on over to Tim? Thank you very much, Mr. Pengas. You can ask any other questions that you have. We can always go back to Mr. Pengas as well. He's staying for the whole duration of the talk. Thank you for that.
Social distance.
Okay, so thanks everyone for taking the time to tune in tonight, and thanks to Giles and the team at Össur for the invite to talk tonight. So I've got about 20 minutes to cover rehabilitation considerations around cruciate ligament injuries, which if we're going to take a deep dive on that, we'll be here for a week. So we're going to sort of skirt around some of the stuff, hopefully address a couple of the questions that was asked at the end of Mr. Pengas's talk, and really kind of get a flavour for where we're using rebound bracing in conjunction with rehabilitation of these guys at our knee unit in Cornwall. So just to confirm that, likewise, I've got no conflicts of interest or financial gains to disclose from this. So cruciate ligament injuries, they gain a lot of publicity. We get quite interested in them, and really because we see a lot of sports people and elite athletes suffering them. And so just three sort of examples of individuals who have sustained, so you've got Gareth Anscombe, who unfortunately ruptured his anterior cruciate ligament just before the Rugby World Cup last year, and Leroy Sané, who ruptured his ACL before his proposed move to Bayern Munich at the beginning of the season. And then for the rugby aficionados down there, out there, this is Tanner Umaga, who in the 2003 World Cup ruptured his PCL in the first game against Italy. And New Zealand members of my family tell me that if he hadn't done that, they would have won the World Cup rather than us, which maybe or maybe not. So when we're looking at this I kind of look at this as a knowledge scale of kind of what do we know around bracing, what do we know around rehabilitation. And I think it's fair to say in the PCL as a unit, we're far more comfortable with how we use the rebound brace, and it's a real integral part of how we manage these knee injuries. Whereas on the flip side of the coin, rehabilitation of PCL really is kind of in its infancy, really. And I think that's partly reflected by how infrequent these injuries are, but also there just really hasn't been the volume of research done on it, because the level of interest in trying to deal with these injuries surgically, where a lot of the financial support was around research, was really driven by some pretty disappointing or perceived disappointing sort of clinical outcomes following them in the early days. Whereas on the flip side with ACL, we we don't really fully understand the role of the ACL rebound brace totally at the moment, as Ioannis has alluded to in his talk, but I think hopefully everyone can recognise that our knowledge around ACL rehabilitation, particularly over the last few years, has grown quite exponentially. So if we start with the PCL, just because, again, this is where we do use bracing far more commonly. When I started getting interested in the lower limb, back probably around nearly sort of 15 years ago, and when my career was starting to shift more into the lower limb, there was really very little out there to guide me from when I started coming across PCL patients, either operatively or non-operatively managed. And this was really kind of the sort of papers that I was going to try and get some guidelines on it, really. And so this is a level 5 expert opinion review from this chap called Dr. Finelli. And when you kind of look at the detail of what was in the regimes that were being advocated, you see they're incredibly conservative, where people were not really getting anywhere near full weight bearing till around 3 months from surgery, and range of motion was really quite restrictive. And that was basically around the lines that this predated any form of PCL brace, so they were heavily reliant on using just a simple functional brace locked in extension to try and control the tibial translation. And as Ioannis alluded to, people were reporting good subjective outcomes, but were sort of, the outcomes looking at the degree of posterior tibial translation were fairly sobering. So Leprard, who really does probably win the gold medal for soft tissue knee research, his group's a really prodigious publication group, started taking this on a little bit more, and this paper was from 2013, and this really does form the cornerstone of our current understanding of PCL rehabilitation. There's not a huge amount more that's progressed on from this, and you'll notice in this paper, actually, things are still fairly guarded for the first 6 weeks, and this was using the jack brace, but we were starting to see an increase in kind of people getting going for the first 6 weeks non-weight bearing, but after that, we really were starting to able to start pushing the sort of rehabilitation in a slightly more aggressive manner. And really, this comes down to some of the biomechanics of what we understand around the PCL. The PCL, as Ioannis alluded to, provides more stress and support to the knee with increasing flexion. And in this Markloff paper, they were able to show in a double bundle PCL reconstruction, which is probably not as commonly done in the UK as maybe it is in America, that actually once you start really starting to increase the degree of flexion, the stress and strain going through the PCL really does start to increase quite dramatically, and as a result, it's always going to be prone to getting stretched and stressed through either the effects of gravity or just the sheer forces that it's been subjected to. And going back to the question at the end of Ioannis's talk about why the PCL heals, this paper does give quite a nice overview around the biomechanics of the knee. It's quite in-depth, and it's not the easiest of reads, but it does talk about some of the healing potential of the PCL, and that essentially boils down to the fact that it is extrasynovial, and so it's not subjected to the same stress that the ACL is subjected to from the synovial fluid. And so if we can stick it in a reasonably good place, it does have a reasonable chance, much like the MCL, of potentially healing or scarring down or scarring itself back onto something useful. So to look at kind of the historical perspective of PCL bracing, so we've seen the initial iterations of just a functional knee brace, which then progressed into the jack brace, which started to come online probably towards the end of the last decade, which we started to see some of our PCL patients going into. And then really, the situation has improved quite dramatically with the advent of the dynamic bracing options, which certainly locally, it's really quite profound the impact this has on people who suffer, particularly multi-ligs or the isolated PCL, where we can convert sometimes a multi-ligament either into a single ligament ongoing issue, or in some cases a zero ligament issue where they can avoid surgical intervention completely. And again, another Laprade paper who looked at this in combination with some of the PCL single bundle reconstruction stress strain data. And I think it's important to clarify that this was done in healthy individuals. So whilst it's given us some really good biomechanical information, what we don't know completely is whether this applies strictly to people who sustained an injury. So we do need to interpret the data carefully. But hopefully what you can see from the three different graphs is, compared to a static force brace, by adding dynamic force brace, the amount of support that it offers on the tibia by allowing it to be in a more appropriate position through either flexion in this top graph, or an unloaded flexion, sorry, or in a squatting position in the bottom graph. It really is sort of night and day in terms of the support it confers. And when we compare it again to a PCL reconstruction, it's clearly not the same as a reconstructed ligament, but it does provide a significant amount of support compared to more static bracing options. And really, that's kind of where we've got to with PCLs. And again, these are a couple of nice papers that again have come out sort of slightly more recently, looking at I beg your pardon, so the current sort of concepts around PCL rehabilitation, which unfortunately, like a lot of rehabilitation papers, really do come up with the summaries of saying more research is needed, clearly. And I think it's fair to say we're probably about 20 years behind where we are with the ACL with regards to our current understanding of rehabilitation. We don't really understand totally who can manage with or without reconstructive surgery. And the long-term clinical outcomes, again, is a bit of an unknown, and certainly more work needed. So if we then flick into territory which I'm sure most of the audience, being rehabilitation specialists, will be far more comfortable in, with the anterior cruciate ligament. So anterior cruciate ligament reconstruction surgery is commonly advocated to try and support the knee from sustaining secondary knee injuries. And a lot of the data comes from surgical ligament registries, which show that if you basically delay, the longer you delay your ACL reconstruction between injury and subsequent surgery, the more risk you are of establishing a chondral injury or a meniscal injury. Now, again, that is probably without doubt and without argument. Whether it is the case in every single ACL injured knee, I don't think we fully understand that. The data, I think, is obviously retrospective, and it is potentially open to selection bias critique. So whether this runs true with every ACL, I don't think we really know, but clearly we have a good understanding that we need to protect these other secondary structures, but not necessarily completely sure in who. And that was really, the cat was put amongst the pigeons slightly by this now slightly, or probably very seminal paper by Richard Frobel back in 2010, who looked at a level 1 RCT, randomizing ACLs into either rehabilitation plus early reconstruction versus rehabilitation with the option of delayed surgery, and was reporting similar outcomes in both groups. And interestingly, when they looked at this 5 years later, actually had a very similar instance of secondary meniscal surgery. So in one group that had delayed reconstruction surgery, they had approximately 32 meniscal tears, and the ones that went for early reconstruction ended up having 29 meniscal tears in their cohorts. So again, we don't really totally understand in terms of the level of sport they got back to and activities. So, but I think we need to try and understand a bit more the individuals that would benefit from early reconstruction versus trying to push on with non-operative management with the option of delayed surgery. And sometimes, again, it becomes a polarized debate I see sometimes on social media when we get case reports such as this of an English Premier League footballer who returned back to playing and I believe is a Spanish international, now back playing for Spain, and is still available for selection following a non-operative management of an ACL injury, which he hasn't gone on to sustain any other injuries that I've heard reported. And it can, and as I say, it brings about this sometimes slightly polarized debate between physio and surgeon, which I'm not sure is particularly helpful, because clearly there's nuance within all of these patients and really does require a degree of collaborative working, which I'm conscious I'm fairly, I think I'm pretty fortunate. Mr. Pengas and my other surgeon colleagues may not feel the same. Fairly fortunate to work very closely with the surgeons, and we can have some good, robust conversations about management options and really keep each other well informed as to how we're going with our patients. So moving on from there, Giles has hopefully got a poll for you.
Yeah, so this is just how do you, what do you use to assess muscle strength through rehabilitation of cruciate ligament injuries? Do you use an isokinetic test, a handheld muscle dynamometer, or manual muscle testing? So we'll leave that one up for a little while. Those answers are coming through. We're up to about 50%. I'll just leave that on for a little while longer. So we're up to about 70% there. I'm just going to end that polling and then share those results. So 11% use an isokinetic test, 12% use a handheld dynamometer, and then 77% use manual muscle testing. Okay,
great. Thanks, Giles. So kind of on the background of that, what I wanted to sort of talk about is really from the rehabilitation perspective, how can we identify people who may or may not be copers with an ACL deficient knee? And this paper back in 2000, I want to say 2008, really started to define those who may be copers, non-copers, or adapters based on their activity levels. And if you haven't read this paper from Hegger-Grindham's group, I would certainly recommend this. And essentially what this paper has shown for those people who are female of an older age group and don't necessarily want to get back to level 1 sport, so i.e. things like football, rugby, netball, we can be fairly confident on the premise that we've got some robust objective data as to how well these people may or may not progress through a non-operative course. And actually within this study, they published an algorithm based on how people do with objective testing data as a prediction model through some regression analysis to show how well people may well do at 2 years following a non-operative course. And essentially, I haven't put the equations up there. You can go look at the paper if you're interested in it. But essentially, if you have a 30-year-old female who scores 90 out of 100 on a Q score for the ADL element, and then has a quadriceps limb symmetry index greater than 90%, the modeling would suggest they have an 85% successful outcome at 2 years without the need for an ACL reconstruction. Whereas if we look at the same individual with lower metric scores, so Q's ADL at 65 and a limb symmetry index of less than 90, the chances of them actually having a successful outcome of non-operative management at 2 years drops considerably to 29%. So the important take-home message from this is test, don't guess with your patients. And this is, I personally have a handheld muscle dynamometer, which we'll talk about in a second, which I would really strongly encourage people to push to get, because the data that it confers is really valuable. And so within that group, what they did is they tested people at baseline, and their baseline they defined as essentially someone having a cool knee, so a knee that we would ideally be looking potentially to operate on. So there's no joint fusion, there's normal range of motion of the knee, and pain is not a factor. They were then subjected to this 5-week exercise program that's been defined by Ingrid Etson's team way back in 2002, and then retested. And so this is the handheld dynamometer that I use. and this is kind of the regime that I would use to test them in to work out a muscle torque. And we know basically that there are several studies that have been published now that have shown that actually this is an acceptable way of defining muscle asymmetry in this patient group. And it's quick, it's easy, it's cheap, relatively compared to an isokinetic machine, which will always remain the gold standard. But from a clinical point of view, the reality is we will never be able to get those in the NHS. And then based on that, I would just some real simple tip, my sort of top tip take home around program design for rehabilitating both groups of cruciate ligaments would be looking at what I call the repetition maximum continuum, and looking at how you're setting up people to achieve particular training goals. So if you really truly want to establish strength with someone to help address that limb symmetry index, they need to be working way down at 5 repetition maximum. So for whatever intensity they're working at, they shouldn't be able to get a 6th or a 7th rep out. So you'll see that as we go along this top row of the strength, we'll still get a degree of strength benefit, but the gains that you see are significantly less than what would happen at a lower rep range of higher strength, because the specificity of training shifts into different particular muscle qualities. And then again, just some similar data that's been produced by Leprard around the ACL brace, where, as Ioannis has alluded to, it's a place that we're still looking to find a home for this conclusively. The adolescent pediatric case is very much there. I think those who have an ACL deficiency with intact menisci, potentially early stage, that may have some benefit, but again, we're going to need to look at that from clinical data as well as research data to substantiate that. So really, just to summarize it all, both operative and operative managements have pros and cons, as we've alluded to. PCL, we've got a really strong, I've called it emerging, but actually I think we're really quite comfortable with the role of dynamic bracing in the PCL, whereas on the flip side of the coin, the rehabilitation strategies we're not as happy with, and that's sort of in direct contrast to the ACL. Based on Hegger Grindham's patients, to help support you, your patients, and the surgeons that you may work with, define who those patients are going to need to be to go through ACL reconstruction or may benefit from non-operative management. I really would push you to get some good regular objective data on how the knee is functioning to support that decision making. And Ioannis and some of the other team get a little bit bored of me sort of this sort of little strap line of mine, so saying test, don't guess. And you know, the final thing is that you can't underestimate the benefits of the collaborative working. It feels silly that I have to say that in 2020 with so much that we know about the ACL and PCL and how it is very much a holistic team approach, but there is no one size fits all, I think it's fair to say, with all these patients. And that's all I've got to say on that. So thank you very much.
Brilliant. Thank you very much, Tim. There's just a question from your section, just with regards to your rehabilitation program for the quads following a cruciate ligament injury.
Yeah.
What sort of program do you go through in those instances?
So I suppose it depends. If it's an acute one, I'm a big fan of muscle stimulators. If they have got a lot of quads inhibition, I don't think there's any sort of magic recipe. I think it is. I use the sort of Eitzen protocol for my early stage rehabilitation, and personally, we don't have access to good gym facilities in an NHS environment, but outside of an NHS environment, I'm a big believer in getting these people back in the gym as quickly as we can, and really start loading them up as soon as we can. If they're a reconstructed patient, again, I'm very keen to get them back in the gym as quickly as we can, but depending on the graft type, which both the ACL surgeons I work with for primary ACLs will use a hamstring graft, and we don't really put any loaded quadriceps work on that till the 12-week mark. Sorry, the 6-week mark, I beg your pardon. and then we'll really push that range once they get to the 12-week mark from an open chain point of view.
Okay, it's interesting you mentioned about reps to max and its role in strength. Actually, this subject was covered quite a lot by Dr. Claire Minchell in the 8th of our key opinion leader webinars. So for members of the audience that haven't seen that, it really expands a little bit on what Tim's mentioned about reps to max and its role within building strength and symmetry within the lower limb. Okay, so thank you to Tim and also to Ioannis for their fantastic talks. If you have any further questions for them, do please put those in the Q&A or the chat function, and we will come back to those during the later session. What I'm going to do now is just show you a little bit about the brace, just for your information. So we're going to start with the rebound PCL. So I'm going to go over to the table camera first of all, and just talk you through the brace and a few of the functions that we have with that. So in terms of the PCL brace itself, we have, as you can see, a significantly longer brace than you might have for some other conditions. With this, it's to do with the amount of lever arm that we need. And within the brace, we have this cable system here, which has a direct connection to the dynamic tensioning system. And this basically means that as we flex the knee, you can see if you watch this yellow marker here, there's a direct connection between the anterior directed force and the flexion angle provided by the brace. So I'll go on to explore that a little bit more, but you can see I've marked it with a yellow piece of tape here, but as we flex the brace, that force increases in order to counteract the posterior directed force or the increased tension that Tim mentioned in his talk. Now, with that comes the possibility that we need to tension that correctly. So the last thing that we would want is for this to be tightened up too high, and we would then generate that anterior directed force beyond what we would clinically need, therefore potentially putting the ACL structures at risk, for example. So you can see there's a diamond formation on here, and there are associated torque wrenches that allow you to tighten these up. So it's a little difficult to show you this against the white background, but these actually clip into the posterior section, rotate round, and these allow you to torque the whole set up in order to get the correct tension for the patient. The other thing that's extremely important, that when you're applying these, you always need to make sure that this position is nice and centrally, and you can see if I shift that out of the way, there's a mark there just to make sure that you've got this in the correct position. Now, because it's torqued, what's really important is that we make sure that after a period of 2 weeks post application of the brace, you may need to actually reset these. So normally, once this has been applied, patient wears it for a period of 2 weeks. There may be some circumferential or volumetric changes. It's important that this is reset. So we do this by just placing a pen in this section here, pushing laterally, and there's an arrow that directs it that way, and this can reset this system, and this will rise up like that, and you can then re-torque it at that review appointment. So really important to be aware that you do need to adjust that. And there are also different torque settings, different torque setups. So the standard one that applies a 44.5 Newton anterior force in full extension is the white. We then have a grey if the patient has an associated ACL issue. You then go down to the grey, and you then have a black one used a lot less, and that one is an 18 Newton meter force. The grey one is a 31, and that one's used if the patient exhibits any discomfort, perhaps. So you have options for adjusting these dependent on your need. So I'm just going to go back to the main presentation, and then just cover and show a little bit about what a similar graph to what Tim mentioned, and this is taken from the Laprade study, and effectively this is the force that goes through the PCL as we go through flexion. So starting at the bottom, we're starting off here at around sort of 40 newtons, and then this force increases as we go through to flexion. So in this case, you can see that this force increases up to in the region of about 140 newtons that we have there. Now, this is the blue line really shows what the brace is applying. So it's following that level of that tension curve as found in the Laprade study and mimicking the biomechanical situation in the knee to provide conditions that PCL can heal. So we're not in effect separating that ligament while we're going through that healing process. It's allowing an environment within which it can heal in a non-elongated position. Now, there was another question earlier. There's another question earlier, just basically saying, what is the difference? Why is this dynamic when there are other supposed dynamic braces? Now, with other more traditional braces, there is often a spring-loaded or some method of applying a supposed dynamic force, but this is actually fixed, normally up to a maximum of 70 newtons. And one of the difficulties with that is it doesn't change throughout the flexion range. So you can see potentially at this section here, we're applying too much of an anterior directed force. And then more concerningly, as we go into a higher degree of flexion, you can see there's a big differential between the force required and the force that these are applying. So that just goes to describe the difference. So the real thing is the connection between flexion angle and the dynamic anterior force. So what I'm going to do now is just go over to fit the brace on Stewart. So it's going to pop over to him, and I'm going to go and pop all sorts of PPE on. So there's going to be lots of rustling for a minute. So again, another week with Stewart with his legs out. I'm nearly there. Okay, so I'm just going to bring the brace over into position. Now, first of all, from a measurement perspective, the thing to be aware of is we're measuring for the brace with a circumference 15 centimeters above mid-patella, 15 centimeters below mid-patella, and then taking a caliper measurement across the joint line. So in this instance, we would generally use a CF caliper, as we would term, and if you need one of these, we can send you one of these. But effectively, it's a spring-loaded caliper that allows us to get a measurement across the joint line. It's important you allow this to settle, so the spring-loaded measurement. And I'm then taking a reading from this section here. So in Stewart's case, it's 10.7 mil. And I'll just reproduce this for you guys. But you can see the purpose of this spring loading mechanism is that it takes out some of the error in measurement, so that we're making sure that clinicians aren't sort of applying untoward pressure or indeed not applying enough pressure. Now, moving on to the brace itself, all the straps are numbered. So I'm just going through number 1 first of all. 3 down the bottom. You'll see that the strap just above the center of the hinge has both 2 and 5 on there. And the reason for that is you need to adjust that twice throughout the setup. And I'll show you that a little bit later. So when we come to applying the brace, obviously with the patient, what's incredibly important is that we're making sure we're maintaining joint congruency. So whenever we are lifting the leg, often with a degree of support from someone else perhaps applying the brace, but we're applying an upward force controlling from the posterior calf to make sure that gravity itself isn't pushing the tibia down like that. Okay, we're sliding the brace into position, and the landmarks that we need to be aware of are the patella. I'm just going to lift you up a touch higher there, Stuart. Into position, and you can see that we've got that position nicely. So condyle pads, and we've got these positioned just a little bit above, superior to mid-patella, and this just allows the brace to settle into position, and then we would then fasten strap number 1. So going through here, placing that through, and we can trim that if we need to. We're then going to strap number 2, passing that through the D-loop, and going back on itself, centering that pad just to make sure that we've got that in position. Okay, and then going down to the bottom section. Now this one actually has, you can see it's got a pad here, and the function of this is to make sure that we're not applying untoward pressure across the shaft of the tibia. So going through the D-leaf, as I mentioned, back through and into position. Okay, number 3, up to the top, number 4. Again, adjusting that pad as required to get it into position. And we then revisit number 5. Now for number 6, this is at the back, but what I'm going to do is just pop over to the treatment area and show you that one. But you can see we've got a really good setup here. We've got good support on the joint line, and we can also, although we didn't need to in this instance, if we need to, we can actually change the condyle pads. So there are different thicknesses of condyle pads dependent on what we would need in order to set this up. So in this case, I'm going to get Stewart to have a stand and a wander over, but we would normally set this up, including the torque on the patient. If the patient is unable to stand for whatever reason, we would gently log roll them onto one side and then torque the system up from there. Okay, so I'm going to go over to the treatment area. Stewart's going to pass over and we're going to torque this up. Okay. So he's just wandering over now. Okay, so if you can spin the other way for me, perfect, Stewart. So what we now need to do is tension strap number 6. You can see this one here. Now, if you turn with your right side towards the camera, please, Stewart. We need to make fine adjustments to both strap number 5 and strap number 6. Now, this is particularly important to make sure that we've got the hinge in the correct position. So exaggerating, but if I tighten this one too much, can you see the hinge is moving posteriorly? But what we want to do is provide a balance between the tension on those two straps. So again, we're making sure that we've got this hinge positioned equidistant between the front and the back like that. Okay, so what we would then do, if you can spin around for me here, Stewart, is we would then tension, sorry, showing the back, perfect, then tension the dynamic tensioning system. So we're using our torque key, as I mentioned before, preset at 44.5 newtons, place this into that diamond shape at the back, and we then rotate this smoothly. So as we do this, we're increasing the tension, and this will then snap off at the correct tension. So what I'm going to do is just take the dynamic camera and show you this up close, just so that it can be a little bit easier for you to see. Okay, so we've got this positioned in position there, and we're tightening this as we go, and you can see once we achieve that 44 newtons, the two separate. And it's a very safe system because it then means that you can't over tighten the system. So if you turn, see with your side to me, please, Stewart. What we can now see as the patient goes into flexion, so if you do a bit of a squat, you can see just here that there's an increased tension as we go into higher degrees of flexion. To follow that graph that is set out by Leprard, as we go into higher flexion, the anterior force increases dramatically in line with the flexion range of motion. So whatever position of flexion the knee is in, it's going to have an appropriate physiological anterior force associated with that flexion angle. So potentially from a physio perspective, this opens all sorts of different rehab opportunities where normally for PCL reconstruction, you would be normally limiting range of motion, often with a knee immobilizer or something similar. This allows you to increase the degree of flexion that you start using potentially to an earlier stage and participate more fully in the rehab using that higher degree of flexion. Now, if you turn with your back to me there, Stewart, I'm going to just pass round to the other side. Now, one of the things you can also do is it does actually have these functional healing sticker, which is a tamper evidence seal. So what we don't want is for the patient to adjust these. So it's really good that you can cover that, and it makes it evident if the patient has adjusted it or whatever. So, but as you'll notice, it's an unusual sort of proprietary diamond. So it's not like they have an Allen key and they can adjust that. Okay. So what I'm going to do now is just go over and talk you through the ACL. So following similar lines, but for a very different biomechanical situation. Okay. Right. So moving over to the table camera. When we then look at the ACL, slightly different. The length is a little bit shorter, and as Mr. Pengas mentioned about its potential use in slightly younger patients, the inseam measurement for this, we don't sort of concentrate too much on age because obviously different patients can be different sizes, but the inseam measurements can be as low as 25 centimeters, so effectively groin to the joint line can be down to 25 centimeters. So that's always a good measurement to take if you're unsure about the length of the patient and their suitability for this. The dynamic tensioning system, you'll notice, is actually on the thigh here rather than applying a posterior directed force on the shin. Now, one of the things that's particularly important for patients, ACL patients post-operatively, for example, they would often have operative wounds, dressings in this area. And if you think about the tissue that's covering the tibia, there's not a high degree of soft tissue covering. We have, effectively skin over bone. So it's really important that we're loading an area that's more suitable to applying pressure. So rather than applying a posterior directed force on the tibia, we're applying an anterior directed force on the femur. So effectively moving the femur relative to the tibia, rather than more traditionally moving the tibia relative to the femur. Now with this, you can see that as we flex to 30 degrees, this tension increases and then drops off like that. So what I'm going to do is just go over to the graph in a moment. But first of all, I just want to highlight the differences in the torque wrenches as well. So if you look here, the torque wrench is very different, and the setup of the dynamic tensioning system is very different. So it's a sort of a double hexagon setup. And part of the reason for this is because the force required to set this up and tension through the ACL is 125 newtons when in full extension. So it's the standard setup for the white torque wrench. And if you need a lower force, for example, guided by patient discomfort, or for example in an allograft patient, we have a black torque key which is preset to 88 newtons. So you have different setups for different individuals. There was a comment from Steve Hunt, I believe, about how to know which sort of setup to have for each individual patient. Generally, you would use the white torque wrench for both the ACL and the PCL, unless you have associated other problems that you were concerned about. So in the case of the PCL, it's involvement of the ACL. You would then go down to the grey or intermediate one. Or in the case of the ACL, you go down to the black one if you have discomfort or you have an allograft patient. So it's just important to mention with that. So I'm going to go over and look at the graph at the presentation. So when we go over to this, when we're actually looking at the graph for the ACL, bear with me, you can see that there's a very different force setup when looking at the ACL. So again, the force is a lot higher. You can see that it's in the region of 125 newtons. You've got a significant increase as this goes up, and then a peak at 20 to 30 degrees, and then a significant reduction in that tension as we go into higher degrees of flexion. So when we look at this, effectively, the brace is modeled to follow this curve, and make sure that we're applying, again, a correct biomechanical force to keep that joint congruency, to hold that in position. Okay, so what I'm going to do now is just go over and fit that to Stewart. So again, I'm going to swap legs. So this one is a left, and what we can actually do is set this one up. So again, what I'm going to do is just undo these straps either side. I'm actually going to need to trim this one into position. And similar to some of our other products, I mentioned it with the spinal range, but it's blue is used, so the patient can actually adjust these straps. So those are marked with a blue touch point. We also have the ability on both braces to adjust just the flexion angle. So if we're adjusting extension, it's the one anterior, and flexion is the one posterior. And what we can do is take the adjustable condyle pads out, and you can just about see that there's two screws. Anterior for extension, posterior for flexion. And again, we can make adjustments to those condyle pads as well, should we need to. Okay, so I'm just going to lift the leg, place it into position, and then we'll set up from there. So again, making sure that we've got this position correctly, but we're obviously, gravity is working with us in this instance, because what we want is for this to remain congruent and in position. So slightly different setup in terms of how we're supporting this. And again, making sure that we've got the hinge a little bit superior to the patella, and going through this numbering system. Now on this brace, the first strap has a significant shell on here, and you can see that this is designed to be contoured to fit the shape of the patient. Make sure that that's positioned nice and centrally. Place that through the D-ring, and then fasten that back there. So in this case, this one's a little bit long. So what we can do, all the straps have these crocodile Velcro sections. So we're just going to trim this over like that, position it nice and centrally, into position, and then place our crocodile Velcro section back into position and fasten that up snugly. Okay, so moving on to the next strap, number 2. Again, this has a pad just to make sure that it sits nice and central. I'm going to shift that one up a touch just because I positioned that one a little bit low. Into position. Place the second strap over, like that. Again, trim as necessary. In this case, I'm just going to fold it. Okay, and we're then going up to the third strap. So exactly the same. One at the top. Place that through. Fasten that into position. And then with this section, we're bringing this through. And this again is both 4 and 6. So detach this here, trim this into position. So in this case, I'm not going to trim it, I'm just going to fold, and you can do that if you're wanting to just double check before you start. Position that, and then fasten that into position. Okay, number 5 is posterior, and we'll come back to that, and we'll then come back to number 6. So position is nice and central. We've got it just a little bit superior to the patella, just so it will actually seat once we've got it in position. And I'll go over to the treatment area, and then we'll then readjust accordingly and set up the dynamic tensioning system. Okay, so Stuart's just going to come over, and we're just going to go through the setup of this. So often what we would actually do is set this up on the patient. You're going to have to spin around because I can't see the leg. Thank you, Stuart. So we've got it set up here. So what we then need to do, again, similar to the previous setup, you spin around so that you're facing, your back is facing. Number 5 allows us to, again, position the hinge here. So we're going to tighten this one up. And if you come round to the side, Stuart, so this side is facing the camera, rotate round, we can use the tension between these two to make sure that we've got this positioned correctly. So halfway, anterior, posterior. So in this case, I'm just going to tighten this one up a touch in order to get it positioned correctly. So we've got that there, and we can then readjust number 6, this section here. So when we actually come to tension it, Stewart, if you can turn with your back to there. So we're placing the torque key in position here, and then I'm going to go to the dynamic camera just to show you this setup. Okay, so you can see that we've got our dynamic tension system key in there, and what we're doing in full extension for both braces is always really important that we've got the leg in full extension when we're tensioning these, but we're gradually increasing the tension on here. You can hear it clicking, the pull is locking within the system. We keep going until it actually snaps and stays into position. So there we go, and you can see it's designed that two parts separate. It's a very safe system in that you can't actually tension it too much. Okay, so if you turn with your side to me, Stewart. Okay, and then if we just go into slight flexion, so to about 30 degrees, and you can see that there's a significant tension as we go to 30 degrees, and then as you go to full extension, you can see that distance in effect increases. And it's a little bit more subtle in the ACL brace because of the comparative differences in the forces going through there. So obviously we have to tension it much higher because the tension is much increased in comparison to the PCL. But obviously with the PCL, the force increases greatly as we go into higher flexion. So as I mentioned, a peak at 20 to 30 degrees with the ACL. Okay, so with both these braces, with the PCL and the ACL, there are custom versions available. So if you have a patient who's in an unusual shape, for example, you can actually do that. Obviously, Stewart is a relatively normal shape, so we've been able to fit him from an off-the-shelf design. So again, a 15 centimeter circumference, 15 centimeters above mid-patella, 15 centimeters below mid-patella, and then a width across there, then gives us the most appropriate sizing. Okay, so I'm just going to go and see if there are any further questions from there. If you have any further questions for Mr. Pengas or for Tim, do please pass those through, and we'll endeavour to answer those. I'm getting rather warm, so I'm going to take some of my PPE off. Ooh. Okay, so just to have a look through. So we have a few questions in here. Steve, I believe, put a question in about how much force or torque to apply. So I mentioned that earlier. Generally, in most individuals, it would be the white torque key. If there's ACL involvement, you would consider going for one of the others. In the case of the PCL. There's also a question, is there ever any need for range of motion stops? And does the brace incorporate any stops? So as standard with the Rebound PCL, it comes with a 0 extension stop and a 105 flexion stop. This basically follows on from Lepard's rehabilitation criteria. With the ACL, it comes with a 0 extension stop and a 90-degree flexion stop. If you do require much sort of a definitive range of motion kit, you can order that to come with the brace. So it will come with, if you ask for it, it will come with a set of stops with those at 10-degree increments. So you do have that option. There's also a question from Jamal. If you have a patient with a medial compartment OA and the tool in the ACL, can this work? Yes, potentially. I mean, obviously, with using the standard brace, we're just providing a stabilizing force and not necessarily providing unloading. But if you're wanting to consider using a custom brace, we can actually build in a degree of varus or valgus angulation dependent on your needs. So if you're using the smart dosing system in order to measure for that, it's always worth putting that in the free text box. And also, if you ever need me as an orthotist to check that over for you, if you've got any questions, do feel free to give me a shout. Another question about the torque key. From Paul Outred, if you apply a white torque key initially and it's found to be too high, how do you detension and apply the grey or black torque key? So I'll go over to the brace. If Stewart can just pass me one of those and just show you the unlocking mechanism for that. So in this case, what we're going to do is just use a pen, and we take the dynamic tensioning system here, we flip this over like that. I'll bring this up so you can just actually see, and there's a grey section in here. So we're putting a pen or a screwdriver, whatever you had. Can you see that slips to the side and then apply an upward pull? So it's difficult to hold this to the camera and do this, but I'm lifting this up and you can now see that this moves freely either side. So that just means it's unlocked. Really important that you make sure that this is positioned centrally. The last thing that we would want is this to be positioned laterally, for example, especially if the patient has any posterior lateral corner involvement. So nice and centrally, following this position, same as your procedure, the 2-week torque check. So that's how you reset that system. And it's exactly the same on both the ACL and the PCL. But really, the key thing is the reason why you'd go down from a white to the black one is more guided by any patient discomfort in the case of either brace for that matter. Okay, so I think that pretty much answers all of those questions. Are there any further questions that for Mr. Pengas or for Tim? We'll come back to those if required. Then the last thing really to mention is that the next session will be on the 15th of July at 7 p.m. And that's with participation from the whole team at Total Orthopaedics. And it's about trauma in the time of COVID, and it's a cross-disciplinary review. So both foot and ankle, shoulder, hip and knee, and also input from their radiographic department as well. So a really interesting topic, an overview, very much an update on where the health system is at with the COVID situation. So last thing really remains to say thank you to Mr. Ioannis Pengas and to Tim as well. Fantastic insight into their use of dynamic bracing. Our sincere thanks goes out to them. If you have any further questions, put those through. We'll pass them on to them and get back to you. So we will then see you on the 15th of July. Thank you very much.